The topic for today is evidence for conservation in salvage laryngeal surgeries. When we talk about the treatment lines for the management of carcinoma larynx, radiotherapy and organ preservation protocols using concomitant chemoradiotherapy stays as the first line. In early disease, mainly T1, T2, and also in T3. When we talk about the recurrence rates of carcinoma larynx, specifically the early stage disease, in T1, T2 glottic cancers, the recurrence rate is about 21 to 37 percentage, and in supraglottic lesions, it is about 30 to 45 percentage. So, even in the early stage, the recurrence rate is in supraglottic lesions, it is about 30 to 45 percentage, and even in glottics, it is 21 to 37 percentage. When the radiation therapy fails or when the chemoradiotherapy fails, total laryngectomy was considered the safest and the easiest salvage option. Since the Centennial Conference on Laryngeal Cancer in Toronto in 1974, they have put a selection criteria and treatment algorithm to identify patients suitable for salvage conservation laryngeal surgery in recurrent laryngeal cancer. And this debate and the plan to go for conservation laryngectomy is continue to evolve and improve. When we talk about the radiotherapy failure in carcinoma larynx, when we club the T1 lesion, it comes around 5 to 10 percentage, and in T2 lesion, it is 20 to 40 percentage. Why there is an RT failure, even in early disease? It is mainly because of the error in initial staging based on the clinical criteria. And it is very important to go for a careful staging after a thorough endoscopic examination guided and aided by imagiology. So, what is the reason for this difficulty in assessing a radio recurrent or a radio residual disease? Because the radiation therapy can cause inflammatory and fibrotic changes in the tissues, and this makes the clinical assessment of the extent of the recurrent disease more difficult because of the post-therapeutic edema, erythema, and changes in the laryngeal mobilities. So, the clinical examination of a recurrent disease by endoscopic examination and imaging, the diagnostic accuracy comes only about 38 percentage, with 10 percentage of the tumors being overstaged and 52 percentage of the radio residual or radio recurrent diseases are understaged. So, to understand the pattern and the spread of recurrent disease, this is very important. We have to understand the spread and the pattern of spread of disease to select patients who would be best suited for conservation laryngeal surgery. So this is an article published in the Wiley Head and Neck about the histological characteristics and the tumor spread of recurrent glottic carcinoma, an analysis on whole organ section and comparison with the tumor spread of primary glottic carcinomas. So what they did was the histological characteristics of 29 recurrent glottic carcinoma after radiation failure was analyzed on whole organ slices, mainly the T1 and T2. The growth pattern of 21 recurrent T3 and recurrent T4 and 52 primary T3 and T4 carcinomas were compared. So they compared the growth pattern of a recurrent disease with the primary T3 and T4 disease. So what they found in their analysis is that in the primary tumor, the growth pattern is almost concentrical. That is 70% of the primary laryngeal cancers or hypopharyngeal cancers, they have got a concentrical growth pattern. But when we look into the disease pattern and the spread, it is multifocal in recurrent laryngeal cancers. And there is high percentage of undifferentiated dissociated tumor cells And there is high percentage of perineural infiltration and higher rate of cricoid cartilage infiltration with the high percentage of contralateral tumor spread in recurrent diseases. So these all make the exact identification of the extent of the disease difficult. And also, the tumor infiltration of the cricoarytenoid joint and extralaryngeal tumor spread is also more in recurrent cases. So, when we approach a radio residual disease or a radio recurrent disease, we should have a clear cut approach. The first and the foremost element in evaluating or when we plan for a salvage conservation is that we have to go for the pre-radiotherapy staging of the lesion, and this has to be compared with the present recurrent lesion. So what was the pre-radiotherapy status and what is the present status? This has to be analyzed and compared. Recurrent tumors, they always have an unpredictable and they have adverse features. So this factor should be informed to the patient, and there is always a need or there is always a need to switch the conservation laryngeal surgery to a total laryngectomy at the time of surgery, and this need has to be well informed to the patient when we are planning for a conservation laryngeal surgery. And the most important element we have to evaluate prior to a conservation laryngeal surgery is the pulmonary function. And the fourth element is the patient should be well informed about the extensive postoperative rehabilitation processes. That is, the patient may have delayed time for tracheostomy decannulation, removal of the nasogastric tube, or the percutaneous endoscopic gastrostomy tube. So these all matters has to be well counseled, and then only we have to go ahead with the conservation procedure. Since it is a post radiation surgical intervention, there is a high rate of local complication. This also need to be well explained to the patient and the bystanders. So coming to the conservation laryngeal surgery, when we talk about the conservation laryngeal surgery, the cornerstone is to optimize both oncologic and functional outcome. That is to eradicate the local disease and to preserve the laryngeal function. And we should consider conservation when there is a high probability of achieving local control in the larynx, and if we can preserve at least one cricoarytenoid unit. And this cricoarytenoid unit is the basic functional unit of the larynx. And what all comprises a cricoarytenoid joint or cricoarytenoid unit is one functioning arytenoid, an intact cricoid cartilage, associated laryngeal musculature with innervation from both the superior and the recurrent laryngeal nerves. So, this is the basic concept of a conservation laryngeal surgery, and this has to be assessed very clearly prior planning for a conservation laryngeal surgery. So, what all are included in the conservation laryngeal surgery? It mainly we can classify into a transoral laser microsurgery or the endoscopic carbon dioxide laser excision of the tumor. Second one is different types of open neck partial laryngectomy. So, when we talk about the open neck partial laryngectomy, it can be laryngofissure with cordectomy, partial pharyngectomy, which can be vertical partial laryngectomy, and also horizontal partial laryngectomy, otherwise called as supraglottic laryngectomy. And the third one is supracrycod partial laryngectomy with cricohyodoepiglotopexy or a cricohyodopexy. So, whenever I am talking about this conservation laryngeal surgery, I will be dealing or mentioning these three surgical procedures in the subsequent sessions. So, this is the article which was published in 1951 in Annals of Otology and Rhinology and Laryngology. The other was SOM. It was in 1951. If you look into the heading, it is limited surgery after failure of radiotherapy in the treatment of carcinoma of the larynx. So people have thought thinking of conservation even in 1951. And in that article, six case scenarios have been explained, and all the six cases are radiation field carcinoma larynx, where they have done a laryngo fissure and cordectomy. So, this is a conclusion that SOM has made is conservative surgery may be employed in instances to eradicate residual disease in selected cases of limited carcinoma of the larynx. The original intention of affecting a cure and laryngeal function preservation may still be realized in spite of previous unsuccessful irradiation. So this was made in long back 1951. After that, people start thinking about the conservation in radioresidual and radio recurrent diseases. So coming to the first conservation protocol or conservation procedure, that is a transoral microsurgery. It is well established in the primary management of early stage laryngeal cancers. The 5-year disease free survival rate in early stage glottic cancer treated primarily by transoral laser surgery is about 81 to 93%. So that's a good 5-year disease free survival in early stage disease by laser surgery. And even though the role of laser surgery is well established in early primary carcinoma larynx, the role in the radio recurrent setting is not so well defined. Why it is because it is not widely spread practice. The reasons are the need for specialized equipment, the lack of expertise, and limitation of transoral access in selected cases. So that is the limiting factor for the widespread use of this laser, mainly in the radioresidual or radiorecurrent disease. So if you look into the literature and if you review the literature, the oncological outcome and the functional results have been reported from different centers. But the problem are the data are very small, and in, because of that factor, we need to pool the results in order to achieve a larger sample size before any confidence can be generated about the applicability of this particular technique in the radiorecurrent setting. So, this is a recent systematic review and meta-analysis. This was published from Newcastle Tyne upon UK, and the main corresponding author is Dr. Vineet Paleri. And they have looked into the oncological outcome of transoral microsurgery for radiorecurrent carcinoma. They have analyzed, they collected a lot of articles based on the oncological outcome of laser microsurgery. And after exclusion, 11 articles were collected. And they selected the 11 articles. So, when they look into the recurrent tumor stages from all the clubbed articles, the major group of tumor was the T1, comprising about 150 out of the 224 patients. 150 patients were in T1 stage. In T2, it was 46. T3, it was 13. And in T4, it was 6. So this was the categorical tumor stage wise distribution of the tumor. Coming to the pooled outcomes for all patients treated with the transoral laser surgery in radio recurrent disease, we can see that in the pooled data, local control at first transoral laser surgery, it is about 56.9. And this local control increases to about 63.8 when we do a second transoral laser surgery. So that is one applicability of laser surgery. We can repeat it. And even after 2, 3 endoscopic laser surgery, if it is recurring, at the end, it will end up in a salvage laryngectomy. There, we pulled the data, the outcome is 88.2. So, the disease-free survival is about 70.9 and the overall survival is 74.8. So, the local control, what I mean to say is the local control with the first transoral laser surgery for a radio recurrent disease, it is about 56.9. And by the second surgery, it increases up to 63.8. And the disease-free survival is approximately 70.9. The mean larynx preservation rate by transoral laser surgery in a radio residual or radio recurrent setting is about 72.3. That is a good number. And this is the recommendation after analyzing the pooled data. They recommended that transoral laser surgery should be offered only in carefully selected cases of radio recurrent tumors, and centers offering laser surgery for radio recurrent diseases, they should have expertise in performing the procedure for previously untreated tumors. There should be lower threshold for avoiding TLM for radio recurrent tumors in favor of open partial laryngectomy, and centers offering TLM for radio recurrent tumors should also offer an open partial laryngectomy service. So this is the recommendation in this meta-analysis. This is the second article by Steiner, that the great person who is behind this transoral laser surgery. This was published from Germany, Steiner and Petra Ambrosch. Transoral carbon dioxide laser microsurgery for recurrent glottic carcinoma after radiotherapy. So this is a data of 34 patients with a local recurrent carcinoma glottis, and these recurrences occurred in a median of 21 months. That is a range of between 5 to 288 months. T1 disease, the recurrent T1 stage was seen in 11 patients. In T2 it was 10, T3 10, and T4 3. So of this, 20 patients, that is 59 patients, had local recurrence after this carbon dioxide laser surgery. And most of this recurrence were T1 it was 3, T2 it was 7, T3 it was 1, and T4, if you see that, it occurred in an advanced stage, that is in 9. 9 is a number. And this happened 43 months after the salvage laser surgery. So when you go through this flow chart, we can see that 34 patients of this after the first laser surgery, 13 patients were absolutely uh, free of disease. 20 patients recurred. Of this, 20 patients, 14 patients were taken up for the second surgery. And after the second surgery, 8 patients became free of disease, and 4 patients again recurred. And this patient again has to undergo a surgery, and 1 patient became non free of disease. And at the end, in this 4 patients, again a recurrent surgery, a revision surgery was done, and 1 patient has been sent for palliative treatment, and 2 patients. So at the end, what is that? 13 plus 8, that is 21, 21 plus 1, 22, 24 patients were disease free. So this is the again the continuation of the data of this Steiner study. When we look into this, the tumor free with preservation of the larynx is mostly seen in the early stage disease, that is 9 plus 6. When we look into the 3 stage and 4th stage, it is less compared to the early stages. And also when you look into the patient status alive, it is mainly in the early stage, the patient is alive and free of disease. So that means that the role is more in early radio residual and radio recurrent disease. So the 3-year and 5-year disease-free survival was 86% for all T stages, with no significant difference between early and advanced recurrences. The overall 3-year survival was 74%, and the corresponding 5-year survival was 53% for all T categories, with no significant difference between early stage and advanced stage. Even though the larynx tumor free with the preservation of the larynx is higher in the early stages, it is less in the advanced stages, but there is not much difference in the disease free survival and a 3-year survival rate as well as in the 5-year survival rate when we compare with the early and advanced recurrences. So they recommended that transoral laser surgery can be recommended for early as well as advanced lotic carcinomas after radiation failure. But the contraindications for a transoral carbon dioxide laser surgery in a radio recurrent diseases, if there is fixation of both vocal cords or arytenoid cartilages, gross infiltration of thyroid or cricod cartilage detectable by CT or MRI, and if there is extensive infiltration of the soft tissue of the neck. So, in these situations, better avoid transoral laser surgery as a salvage option. And salvage laryngectomies becomes higher, or the incidence of salvage laryngectomy increases when the disease is extending into the anterior commissure. So, if the radio recurrent disease is extending to the commissural area, then it is a difficult situation. There is a high possibility for a recurrence again, and we have to go for a salvage laryngectomy. Then the favorable functional results and rare postoperative complications of laser surgery or less hospitalization. So that is one advantage of doing a laser surgery. The other thing is the repeatability. The strategy of repeating endoscopic laser procedure is possible, and the patient has to be well informed. They need to come for regular follow-up, and they have to be informed that sometimes if we develop recurrence, they have to go for repeat surgery also. So these all things are to be counseled when we are going for a conservation in a radio residual or a radio recurrent disease. So with that, coming to the open neck partial laryngectomy, the first one is laryngofissure with cordectomy. What exactly is laryngofissure with cordectomy is, it is we are making a cut in the thyroid cartilage, opening the thyroid cartilage. You are looking into the disease into the endolarynx, and you are taking out the disease from the vocal cord. So to do this surgery, the disease should be a very limited disease, and this is best suited for small mid-vocal cord lesion not reaching the anterior commissure or not reaching the arytenoid vocal process with no normal vocal cord mobility, and only in patients where the endoscopic approach is inadequate. In some situations, the endoscopy will not give correct visualization and adequate visualization. In such a patient, if the disease is very small and limited with no other factors like commissural involvement, we can go for a laryngofissure with cordectomy. So these are the two data. The first one is primary. As a primary, what is the role for laryngofissure cordectomy for glottic carcinoma? So this was published by Moracanella published in Laryngoscope. 33 cases. No tracheotomy was done for these patients, and the local control was 100%. And the 5 year survival rate was 97% with the laryngeal preservation about 100%. So this was in a primary setting. But in the other study by Danidis, published in JLO in 2010, it included 94 patients. The 5 year survival rate was 93%. What they found, even though the 5 year survival rate is 93%, we could see that the survival rate was significantly poorer in patients who were treated for radio residual disease. Of the 5 patients treated with the salvage procedure, two only 2 people survived and 3 people died because of another recurrence. So, in a salvage setting, as a salvage procedure, laryngofissure and cordectomy takes a back seat. The second conservation procedure is vertical partial laryngectomy or vertical hemilaryngectomy. What exactly is this procedure is, we are extending a laryngofissure with cordectomy to include resection of the corresponding thyroidala with the affecting vocal cord, sparing the ipsilateral arytenoid. If needed, anterior commissure or the anterior third of the contralateral vocal cord is also removed. This is called as vertical partial laryngectomy or vertical hemilaryngectomy. So this is the data published in 1991 by Levy et al. The role of partial laryngectomy for glottic cancer after high dose radiotherapy. So 25 patients were included in this study, and these patients were followed up for a minimum of 2 years and a median of 4.4 years after vertical partial laryngectomy. And they could find that no serious wound healing problems were there. Only two patients had permanent tracheostomy, and the swallowing and voice function were satisfactory in all other patients. Two patients, they had a permanent tracheostomy because of the aspiration. And when we look into the patient characteristics, majority of these patients were in T1 stage followed by T2 stage. And when we look into the disease-free survival and the overall survival, 96% of the patients remain free of disease. And they could see only recurrence only in one patient, and that patient had a T2 disease. Here, when the disease recurred, it recurred both in the larynx and the stoma site 9 months after the vertical partial laryngectomy. So they concluded that, and they could find that the overall survival was about 80% at 5 years and 70% at 10 years. This is another study. Partial laryngectomy. This is the same Levy study. The functional aspects of the partial laryngectomy when they were able to remove the nasogastric tube. That was 7 days after the surgery. 92% of the patients were able to start their oral intake, that is 2 weeks after vertical partial laryngectomy, and decannulation was possible within 4 weeks after vertical partial laryngectomy in 88%, and within 4 months in 92%. The medium time for decannulation was 11 days. So they concluded that effectiveness and complications from salvage vertical partial laryngectomy is similar to primary vertical partial laryngectomy, and it can be considered as an alternative to total laryngectomy for salvage. So our next conservation procedure is supraglottic laryngectomy or horizontal partial laryngectomy. The larynx is resected between the preepiglottic and the ventricles with the preservation of the both vocal cords, both arytenoids, and the hyoid bone. Extended procedures may include resection of the tongue base, arytenoids, epiglottic fold, or the superior medial piriform fossa wall. Contraindications for a horizontal partial laryngectomy are involvement of the glottis, thyroid cartilage erosion, tongue base involvement within 1 centimeter of the circumvallate papillae, major preepiglottic space invasion, and deep musculature involvement in the tongue base. So this is the data about the supraglottic laryngectomy in the radio recurrent setting. This was published by Sorensen, and it was published in Laryngoscope in 1986. They looked into the vertical versus horizontal partial laryngectomy, the incidence of recurrences, and how it affected the life. So, vertical partial laryngectomy after full irradiation, 55 cases were there. Horizontal partial laryngectomy after full radiation, 10 cases were there. Non-irradiated cases, they did 15 cases, so total of 80 cases. But when we look here, the vertical partial laryngectomy, 55 cases they have done after the radiation failure. Of this, when we look into the recurrence rate after vertical hemilaryngectomy in irradiated cases, glottic tumor, it was 14 cases. Supraglottic tumor, 2 cases out of 3. And subglottic tumor, there was no recurrence. So out of the 51 glottic tumor, 14, there were recurrences. Out of the 3 supraglottic, 2 recurred. And in subglottic, only one case was there. So out of the 55 cases of vertical partial laryngectomy as a salvage procedure, 16 patients had recurrences, and of this, local recurrence was seen in 10 patients. So in that recurrence, it was in T1 stage in 4 patients, T2 in 5 patients, and one was in T3 stage. So that was the pattern of local recurrence after vertical partial laryngectomy in an irradiated setting by the Sorensen et al. Study. And this is the data after partial horizontal laryngectomy. I told that 10 cases of partial laryngectomy, horizontal partial laryngectomy was done. Of this, 6 patients recurred. So in the vertical partial, out of the 55, 16 patients recurred, whereas in the horizontal partial laryngectomy, out of the 10, 6 patients recurred. So they said that in cases of supraglottic tumors treated by horizontal operations after full course radiation, the surgical complication is quite high. The functional results with regard to swallowing and respiration also is very high. So they concluded that salvage of fully irradiated supraglottic cancer, if you treat by horizontal partial laryngectomy, we should be very careful, and as far as possible, it should be avoided, and we have to go for a total salvage laryngectomy. This is yet another study by Shaw et al. The role of partial laryngectomy after irradiation in the treatment of laryngeal cancer from UK. When they compared the vertical partial laryngectomy and the horizontal partial laryngectomy, 54 patients were treated by vertical partial laryngectomy and 17 patients were treated by horizontal partial laryngectomy. Of this, local recurrence was seen in 9. Out of the 54, 9 patients only developed recurrence. But if you see here, out of the 17, 3 patients had local recurrence, 11 patients had cervical metastasis, and they the death, the disease death in the horizontal, 7 patient died. That is, alive and well is about 35.3%, in contrast with 66.6%. So when we look into the vertical partial laryngectomy, out of the 54 patients, 66.6% were alive, whereas in the horizontal partial laryngectomy segment, only 35.3% were alive. So again, it is giving the impression that the functional outcome and the oncological outcome are less for a horizontal partial laryngectomy compared to a vertical partial laryngectomy. This is the complication data. Out of the vertical 23 patients, 23 patients underwent a vertical partial laryngectomy. Complications was not seen in 15 patients, and this is only from one center. This is a clubbed data from Royal Marsden Hospital and also from the Royal Hospital. If you look into the complication, it is mainly from the Royal Marsden. Vertical partial laryngectomy, 23 patients were there. Out of this, 15 patients had no complications. Whereas in horizontal laryngectomy, 15 patients were there. Of the 6 patients had no complications. So 8 patients had complication in the horizontal partial laryngectomy. So the nutshell is salvage horizontal partial laryngectomy is to be advocated only if the primary lesion is small and it is confined to the anterior laryngeal vestibule, free of the anterior commissure from the start of irradiation. The lesion should be histologically well differentiated, and the patient should have good cardiopulmonary function under the age of 65 and should have a good general health. And some exceptional circumstances are there, such as if there is refusal of total laryngectomy in a borderline situation, in a very limited in a very limited disease, in a similar situation, in a professional voice user, we can go for a horizontal supraglottic laryngectomy. The last one is the supracrycod partial laryngectomy. It is a very good option as a salvage procedure. What exactly is removed in supracrycod partial laryngectomy is it involves the resection of both true and false cord, the thyroid cartilage, both paraglottic spaces, and one partial or full arytenoid. The epiglottis and pre-epiglottic space may or may not be included depending on the tumor origin and extent. It is reconstructed either with a cricohyodoepiglotopexy in glottic cancer or a cricohyodopexy in supraglottic and transglottic one. This procedure is contraindicated if there is fixation of the arytenoid cartilages. If there is significant subglottic tumor extension to the upper border of the cricod cartilage, that is 10 millimeter anteriorly and posteriorly 5 millimeter extension, infiltration of the cricod cartilage or the thyroid through and through cartilage involvement, extensive infiltration of the preepiglottic space, and extralaryngeal tumor spread. So this is the way how the supracrycod, the area above the supracrycod, including the crucod and the vocal cords, are removed. And this is cricoepiglotopexy and this is cricohyodopexy. Again, this is a very recent article, a very beautiful article. It's a multi-institutional series about the impact of supracrycod partial laryngectomies after radiation failure. It was by Pellini et al.'s study. And this is the classification at the first diagnosis. At the first diagnosis, majority of the patients were having a T1 disease and followed by T2. But in the first time of recurrence, the T1 is 36, T2 is 33, T3 is 8, and T4 is 1. That means that when the disease is recurring, it is going to a higher side. And in the pathological staging, it is 26 T1, 18 T2, 23 3, and T4 has become 11. So this is the stage-wise categorization. And when we look into the complications in this particular group of patients, we can classify it into early complications, late complication, and medical complications. Early complications were seen in 21 patients. That is 27% of the patients had early complications. Late complication was seen in 18%, and medical complication was seen in 2.5%. And when we look into the survival data, the 3-year and the 5-year overall survival was 85.2 and 81.8 percentage. The 3 and 5 year survival was also 95.5 percentage. So that means that the oncological outcome is comparatively good in supracrycod partial laryngectomy as a salvage procedure. Only 4 patients died of local recurrence, one of them in spite of the total laryngectomy, and 4 patients died from lung metastasis and 3 from a second primary tumor. And if we look into this supracrycod partial laryngectomy in previously untreated patients, that is 190 patients by Nodo et al. Study, this was compared. This study was compared. Pellini's study was compared with Nodo et al. Study, which was done on untreated patients. There, the decannulation rate was 99.5. In the irradiated present series, it was 97.4. That is almost comparable. And the satisfactory swallowing, it was 98.4 in untreated patient, it is 97.4 in the post-radiation setting. So that means that supracrycod partial laryngectomy is a good salvage treatment modality after radiotherapy failure, and it should be viewed as an effective tool in the modern surgical armamentarium, able to offer high expectation of disease control coupled with the larynx preservation. So one of the safest and the good salvage procedure is supracrycod partial laryngectomy as per the study. This is yet another study by Daganello published in Wiley Head and Neck Science. That is also the supracrycod partial laryngectomy as salvage surgery for radiation therapy failure. They included 31 patients. Of this, loco-regional control was gotten 75%, and the 5 years overall survival was 60%. And the important thing is 89.29, approximately 90% of the patients had restoration of laryngeal function. And most of the patients, about more than 90% of the patients, the time for they were able to decannulate and the swallowing was re-established, and the time for decannulation was median was 27 days, and for normal oral intake restoration was 30 days. So functionally and oncologically, supracrycod partial laryngectomy is a good option. This is yet another article by Gino Marioni, published in Acta Otolaryngologia. This is also describing about the role of supracrycod. This was a critical review. And if you look into that review, we can see that the decannulation rate in all the review articles, the articles included, it is nearing about 100%, except the Lacura study, all the bronze, Pyranos, Tasia study, all the other studies, the decannulation rate is about 100%. And if you look into the 5 year survival, in the Lacura study, it is the data was not published. In the Schwarz study, it was 100%. In the Marche study, it was 86%. And McCabe study, it was 69%. So the 5 year survival also is comparatively equal when we look into the supracrycod laryngectomy. This is a systematic review on the oncologic outcomes of open conservation laryngectomy for radiorecurrent laryngeal carcinoma. This is published in Cancer, and the author is Vineet Paleri. And here also, when we look into that, the local control for vertical partial laryngectomy is 84.4. Supracrycod laryngectomy, it is 94.1. When we look into the disease-free survival, the vertical partial laryngectomy, it is 88.7, whereas in supracrycod partial laryngectomy, it is 91.3. And overall survival is almost similar, 83, 85, 81. So this is the comparative analysis of vertical partial and supracrycod partial laryngectomy and salvage laryngectomy. So if we look into the data, this is what I told. The vertical partial laryngectomy, the local control is 84.4. The disease-free survival is 88.7. And the supracrycod laryngectomy, it is 91.3 is the disease-free survival. So when we look into this data, this conservation laryngeal procedure, the oncological outcome is quite safe. So the pooled data is like that. The larynx preservation in vertical partial laryngectomy is about 85%. In decannulation rate is 96.3. Salvage laryngectomy rate is 13.1 to 16.6. Whereas in supracrycod, the larynx preservation is 83%. Decannulation is about 96%. And salvage laryngectomy rate is quite less compared to vertical partial laryngectomy, 2.6. The pooled decannulation rate is 95.1 and pooled larynx preservation rate is 83.9. So the conclusion was that partial laryngectomy procedures are effective for the treatment of recurrent laryngeal cancer. The evidence is available for earlier stage disease, and the evidence is mainly available for early stage disease, and that itself highlights the selective, how to select the nature of the disease and how to select the patients correctly. Both vertical and supracrycod laryngectomy are oncologically safe in the salvage setting as per this meta-analysis. This is another one published in the Archives, again comparing the endoscopic resection to open partial laryngectomy to total laryngectomy. Group A is endoscopic resection, Group B is open conservation surgery, and Group C is salvage total laryngectomy. The 5 year survival is 95% in Group A, Group B is 100%, and in Group C, 48%. The fallacy may be because in Group C total laryngectomy, the major patients will be having advanced disease. That may be the reason for the low disease-free survival. The disease-specific survival, if you look into the disease-free survival, it is 63% in Group A, in Group B it is 83%, and in Group C it is 51%. And the interesting part is, if you do an endoscopic resection and an open partial laryngectomy, the larynx preservation rate is quite good. That is about 95% in endoscopic resection, and in open partial laryngectomy, it is 83%. So that was about the conservation laryngeal surgery in a radio residual or a radio recurrent setting with an evidence. A word about the role of near total laryngectomy in advanced laryngeal and pyriform cancers. This was published in Laryngoscope from Sultan Pradhan sir and Anil De Cruz team. And what I want to mention is, They did near total laryngectomy, and in 137 near total laryngectomy cases, 15 cases were for salvage. Of this, that is, in 10.9 percentage, near total laryngectomy was used as a salvage post radiation failure. The local control in that particular salvage setting was 93.3 percentage. So again, near total laryngectomy is also a good salvage procedure, and the complication rate are comparatively higher compared to the primary setting. So this can be considered as a salvage procedure, but the most important thing is case selection, meticulous analysis of the disease status, meteorological evaluation, counseling the patient, and then select the patient appropriately, and we can implement this mode of this voice preserving near total laryngectomy even in salvage setting. The most important prerequisite is the interarytenoid and the retroarytenoid tissues should be free of disease, it should be supple, and it should be free of post radiation edema. So let me conclude this session. In light of many improvements in the technique, innovative ideas, novel procedures, new technology in the pathology, imaging, and rehabilitation, four criteria have been set when we think about the conservation, laryngeal surgery, as a salvage option. First and foremost is identify any contraindication for conservation laryngeal surgery. Pick any contraindication there. If it is there, don't do it. Second one is determine the surgical technique that will result in best chances for local control. At the same time, look into the functional outcomes after the salvage surgery, and that has to be compared with the different conservation procedures. And definitely, we have to survey and assess for synchronous regional lymphatic disease and for systemic disease relapse. Thank you.
Divya, can I ask a question? It's a good presentation, though. Am I audible, Divya?
It's audible, sir.
Okay, so it's a good presentation. You have enumerated all these partial laryngectomy procedures, especially in a salvage hold, which has very, very much importance in our scenario, where many of the patients are getting primary radiotherapy. But I think with the mixed audience who are not only head and neck oncosurgeons, at the end of the day, there is big confusion in selecting the appropriate procedures based on anatomical site rather than stage. So you have just compared that supraglottic laryngectomy is then partial vertical, partial horizontal, and compared things like that. So it would have been much better if you had put a chart at the end saying that, okay, this is the anatomical location where this procedure is the best. Or do you think that it can be mixed matched and selected for any procedures? Divya, can you answer?
Sir, 1 minute.
Did I miss a chart because I joined the late?
Yeah, actually, Divya was going in mostly into the evidence part of it, I think.
But for evidence is high end. It is for the person
yeah,
who knows.
all
But
from retrospective data, so it can only reach up to level 3. So that will never happen. Never, you will not have any RCT or anything to
no. I don't want any way for solely. I just want some practical tips.
So what you said, maybe we can have another session on technical details, concentrating on technical details and the case selection details. That is okay. But as far as the background was concerned, I think she has done a good job. And maybe we should have more doubts from the PGs. PGs should have more doubts to come in. Did you understand everything what she told? What is a cricoarytenoid unit? No, it's the skeleton which
Vipin, can you answer? Allow Divya to answer because I asked her a question and is she answering something?
Sir, actually, sir, when we what you asked is how will we choose a conservative laryngeal surgery
Procedure based on anatomical location
based
rather than
on
city.
the
Yeah.
and based on the disease status and the extent of the disease. So first conservation procedure what I told is about the transoral laser surgery. So the in the transoral laser surgery,
Chandramohan, we don't have the time to detail it. That's why it straight went to the concept of cricoid unit and the
No,
cricoid joint.
let Deepa, let
Which is
her
the basis
answer.
for
The
it.
moderator, I don't need
I
answer
have
from
to
you.
wind up the session. That's the
You
problem.
wind up and I'll discuss her personally. Then it's a mockery. Somebody asking question, she should answer. She should be answering in few minutes, 1 minute.
sir, I will tell sir
Yeah,
in
if they finish in 1 minute, Deepa, he's Divya.
yes sir. In transoral laser surgery, the endoscopic access should be good. Visualization could be good. The cords, especially in a radio residual setting or radio recurrent, should be a mid-cord lesion without involvement of the commissure.
Good.
Anterior commissure should be free. And especially there shouldn't be it shouldn't be an advanced disease uh, in a setting of radio residual disease or a radio recurrent disease. If you can go for a advanced laser surgery if you're a very well trained person like Steiner, they used to do for T3 T4, but in centers where there is lack of expertise we have to limit the cases or limit laser surgery to T1 or basically T2 disease. So the selection is laser surgery early disease in laryngofissure and cordectomy. If the endoscopic access is not there, if you can't see the larynx properly through the endoscope, but the disease is a very limited disease with cord mobility, good cord mobility, mid-cord lesion, we can go for a, without involvement of the commission, we can go for a laryngofissure and cordectomy. The third one is vertical partial laryngectomy. In a vertical partial laryngectomy also, the disease should be mainly in the early stage. It should be in the early stage. The arytenoid should not be fixed. There shouldn't be significant cartilage erosion or paraglottic space involvement. And there shouldn't be any pre-epiglottic space involvement if you are going for a vertical partial laryngectomy. In a supraglottic laryngectomy, we should have both arytenoids intact and there shouldn't be disease in the glottis. The disease should be above the level of the glottis. That is, at least that situation we use a supraglottic horizontal partial laryngectomy. In a supracrycod laryngectomy, we can remove the glottis, false cord, even the pre-epiglottic space. Even we can extend up to the base of the tongue, and it is a good salvage procedure for a T1, T2, or even T3 disease in a as a salvage procedure.
Good. Thank you.
We have one question which I wanted to ask about the cricoid unit, no, which we are talking. You have had mentioned two units. It's a single unit actually. Cricoid joint you have two, but preservation of the single unit is what we aim at in doing a supracrycod partial lining. Any question? You understood everything? No? All the discussions are clear. All the you have to generate doubts. So this one you understood. Based upon the possibility of preserving that. Shall we wind up?